Thanks, Rob. So I'm going to talk about central venous obstruction techniques. I'll be honest, this talk is a little bit geared more towards upper extremity because I think we do a lot more crazy stuff when it comes to upper extremity venous reconstruction. Lower extremity, in reality, and I think most people on the panel would agree, it's usually just catheter and wires. And even for upper extremity stuff, it ends up being just catheters and wires. But we see these kinds of patients, big face, big arms. There's a lot of these patients are billed as having, oh, they're just fat, but they're not really fat. They just have these chronic central venous obstructions. So I'm going to go through this pretty quickly, but Keith already talked about, usually we start with ultrasound, and then CT MRV I think is really helpful in terms of planning and feasibility of endovascular repair. This is sort of our prep for a lot of these patients. We do supine, both upper and extremities abducted 90 degrees and maybe a groin access if needed. And these are our toolbox. We use a micropuncture set, long sheaths, hydrophilic guide wires, usually stiff glides. Try to get down into the IVC if you're coming up, kind of try to get them up into the SVC. Just simple catheters, angled catheters are really helpful. Pigtails if you need to measure out lengths. Gooseneck snares, which I'll talk about, some reentry and recanalization catheters, balloons and stents. Rob kind of went over that already as well. Keith already talked about sort of thrombectomy devices and sort of our kit for sharp recanalization. We have these long 21 gauge Chiba needles, which we can put through a Roche introducer set, nitrix wires, gooseneck snares, and stuff like that. And I'll show you these cases, and it'll make more sense as we go through. In terms of stenting, especially in the upper extremity, end-to-end stenting is technically challenging, or end-to-side, sorry, is technically challenging. You have to be able to cross the wire through the interstices of the stent, which can be hard. Sometimes you need a sharp needle to get through. You basically cross, you balloon open the strut, and then put the stent down. So here's a patient, SVC syndrome secondary to hemodialysis catheters, and you can see basically the right side, the right brachiocephalic is open, but right when it gets to the SVC, it's out. I think there's already a stent there. And here what we did, this is basically the cannula from a transarterial liver biopsy set, which is called a Labs needle, and basically we used that to sort of point a 65 centimeter Chiba needle down into the struts of the stent. We passed a wire through, ballooned, and then we're able to do an end-to-side stent. So this is the end and the side. And this is what the guy looked like before, and this is what he looked like afterwards. So sharp recanalization of a occluded right brachiocephalic vein. So again, we were able to get to here. We just couldn't get to here. So we basically took the Labs needle. This is sort of our target was the snare. We were off a little bit, but we're still able to get into that side. So this is just a 65 centimeter Shiba. Basically, you fire down. And again, you can see where CT or an MR pre-op would be very helpful because you want to know where the arteries, the aorta, and all that good stuff is before you start pushing needles into the mediastinum. So this is another patient, jailed left brachiocephalic vein, left brachiocephalic vein stent, which is jailed out the left side. And again, he has acute clot, which we used the angiojet to clear out. We were able to get through the interstices, blow open the struts of the stent, and land a stent sort of end to side. And so again, this is sort of what I mean by the end to side. So this is the side, and this is the end. And this is what the guy looked like in clinic about a week later. So they definitely get better from this. So this is another case, sharp recanalization. I'll be honest, we tend not to start with a needle because we don't like putting needles into people's chests. But here's a patient, again, right brachiocephalic vein occlusion with a previous hemodialysis line. It basically stops here. There's no flow through this. It's all through collaterals and ultimately comes back into the left side. So we tried to get through. That didn't work. So this is actually just the back end of a glide wire. It looks a little brutal. You sort of jam it up there until it sort of pops and gives. And then we sort of do a little run through a guide here and just get free flow of the wire. This is now the front end of the wire. What we'll do next then is snare the wire out to create a rail to basically externalize the wire from the arm. You'll see this come out eventually. Yeah, so we got it there. And then once you have the wire across, it's basically landing stents here because of how far we're going to have the stent down. We ended up doing kissing stents or double barrel stents, which we deployed there. And then this is what patient looked like afterwards. The flow looks pretty good on it afterwards. So this is a bit more of an advanced case. Again, here, coming in from the left side, we don't really see any flow. And what we were able to do is we could really only get to about here from below, and about to here from below. We couldn't really find a good angle to get the needle or sharp wire to make that turn. So what we did is we put a loop snare in the brachiocephalic vein and a loop snare in basically the other end of the brachiocephalic vein on the right. And through the skin, we stuck a needle, and it's called like a gun sight. So basically, we basically pushed the needle through and through the chest, through both snares, snared it out. We basically pushed a wire through and we snare the wire out. So basically now, just to set this up, there's a needle through here, a wire, and then this wire is coming down. You got to reverse this wire because you can't really stent in this position. So we pass a microcatheter up, coming from the groin, back up, and then just snare the microcatheter, pull the wire out and snare the microcatheter. Now we have a microcatheter through and through, basically from the groin out the right arm. Basically pass a wire through, balloon, and stent. And here, actually, the patient had a fistula on this side, so we ended up putting a covered stent here. This is another case, different technique. We used the outback. Again, we were able to get close, but we couldn't really quite complete the recanalization here. So again, you can see here, there's no real jugular vein. Here, the right subclavian vein and axillary vein are open, but the brachiocephalic and the IJ are out. What we were able to do is, oddly, from the groin, we could get up into the jugular, but we couldn't get this last piece connected. So what we ended up doing was actually using the outback and got across it, and then used the outback to puncture. So we used the balloon as a target. So I'm going to play that one more time, and you can see, if you watch the little bubble, when the outback comes out, the bubble pops. So we pop the balloon with the outback, push the wire through. The wire, actually, if you just put a little twist on the balloon, it gets ensnared inside the balloon. You just pull it out, and at that point, then you have a wire externalized, and you're able to stent and reconstruct the vein. This is just a bare metal stent. There. There is an RF wire. For us, it's a little bit complicated to get it to come down because it doesn't live in IR. It lives in cardiology because they use it for other stuff. But so just uses an RF wire at the tip, RF energy at the tip of the needle, or sorry, tip of the wire, to basically burn through occlusions. You do need a grounding pad, and basically use the pedal. And again, you need to know where you start and where you're going. So the advantage of coming from above, going to the heart, is that it's a little bit of an easier target, but the problem is, again, you're going towards the heart. If you're going up the other way, you can sometimes flop down, so you don't necessarily always have the push. But you definitely need a target on each end. You basically push the wire down. You can just then snare the wire out, change that for regular working wire, PTA, and stent. This does work well, but for very long distances, it can be a little bit tricky. Again, there's a stent. So central vein occlusions can be life-threatening, require emergent intervention. Having the right tools is a must. You need the right-sized balloons and stents, tools for sharp recanalization and bailout. Good pre-op imaging to help plan out the intervention is also key. Start with simple. I would say 95% of our cases still end up being just angle glide catheters, a glide wire, and maybe some guide casts to give an extra stability. Sharp recanalization, we typically just start with the back end of a wire because we have it there. Needles, snares, the outback is also helpful. And there's some newer tools like the RF wire, although the RF wire has been around for a very long time. Thank you.